slow, relaxed, diaphragmatic breathing is the definition of breathing control. Okay, you get their shoulders to relax, and you get their respiratory rate to decrease. You want slower breathing, slower and deeper. Okay, so once they've calmed down, you kind of do these in order. Once they've calmed down their breathing, you're then going to add in what's called a thoracic expansion exercise. Okay, which basically means now they're going to take a deep breath and then hold it for 2 to 3 seconds before they exhale. So first you've done focus on the smooth, controlled in and out. Then you add a hold after the in. Okay, so then you would do 3 to 4 breaths with the hold after the inspiration. Then very last, we're going to add in a forced expiration technique, which basically means adding in a huff. Okay, a huff is specifically contracting the abdominal muscles during a rapid exhalation, making sure the glottis is open, and it should sound like a okay, contraction of the abdomen, forced expiration, glottis open. Sound like a huff. That is a huff. The forced expiration technique is adding the huff upon the exhalation. And as an addition, you can teach the patient to take their arms, everyone take your arms, and adduct into the chest to make the expiration even more forceful. Adduction here, not here.
The old I Must song they used to make females sing is terrible.
Okay, so for what type of patients would this forced expiration technique, especially the addition of the arms, be contraindicated for? Osteoporosis, any sort of thoracic pain, rib fracture, they just had an open chest surgery, or hernia abdominal surgery, or car accident, incontinence. Yes.
Oh no.
Okay, so again, active cycle of breathing. You focus on breathing control, slow and controlled diaphragmatic breathing, progressing into thoracic expansion, which is a hold after the inspiration, progressing into adding a forced expiration, which is adding in a huff and or the adduction of your arms into your chest. Okay, you also are going to have to teach your patients how to properly cough and huff. Huff we just reviewed. Cough is when you teach a patient to inhale maximally, and basically the difference between a huff and a cough is the closed glottis upon expiration. Okay, so they should have a slightly open mouth, closed glottis, and again using expiratory muscle to cough.
Doesn't sound productive.
Okay, now there's some post-surgical patients where you'll have to teach them how to cough safely, because everyone has to cough once in a while. So what if they have an incision in their abdomen? How do you teach them how to cough safely? External pressure. Squeeze a pillow or something else to essentially splint the incision so that they can then cough. Yeah, a little bit of flexion so it's not overstretched. Yeah, squeeze a pillow to splint the incision.
Questions regarding the contraindications that we talked about? Glaucoma, potentially? Or any ICP?
Yeah, any increased internal pressure, yeah. Also, if you have increased intracranial pressure, never put them in a head-down position. No Trendelenburg. Okay, so once again, the order. You may put them in a postural drainage position. Then you can perform percussion and vibration. Then you direct them to cough or huff to get the mucus out. The airway clear active cycle of breathing technique would just be something they would do in the non-postural drainage position. Okay, so there's a nice list on page 239 of, it says postural drainage, and it says all positions contraindicated for these, and then Trendelenburg position contraindicated for these. Okay, so review that. Most of them are pretty obvious, so if there's increased pressure, you're not going to increase fluid flow in that direction.
Is that 239, Dr. Momara?
239.
239.
Yeah, I'm fishing.
Okay, let's talk about these.
What?
Yes.
So the things you just talked about, for a patient, how often should we recommend them to do it? Like,
Depends on the patient. With cystic fibrosis, it may be as much as multiple times a day. It depends on the amount of secretion. If there's a lot, they do it more often. If there's less, you don't do it as often. Yeah. There's actually a board question that I remember where it asks, okay, so what would you look for to measure? What would you measure, or what would you assess in order to determine whether or not you should reduce the frequency of postural drainage? The amount of secretions. Okay, so when you're performing these, especially in an inpatient setting, you actually have the patient cough and huff into a cup that has measures on it. Because you're going to document the amount of secretion.
Yeah.
And the color and
Smells
the
fantastic.
And then you're gonna color and smell.
Smells like cornbread.
Texture. You said you can smell people's secretions.
Fury.
That would be contraindicated.
I can't wait to smell an excretion.
Just wait till you get to smell the excretion of a wound.
I can't smell this. Okay, put your nose there anyways.
Actually, most of the time in Southern California, nurses will do it. I heard that. Most of the time. In Southern California, wound care is done by nurses in Southern California, but okay, so let's talk about some specific respiratory muscle training. Okay, so we've reviewed diaphragmatic breathing, which relates to inspiratory muscle training, because our diaphragm is our primary inspiratory muscle. So that's the one we want to focus on. Okay, so you first will focus on the technique and the control, followed by the depth, followed by the strength. And Don't ever put a weight on someone's stomach in front of Dr. Clocky. He'll slap you or have a heart attack. But you may do that in the clinic.
Wish he would.
If he likes to play it safe with something, don't put weights on stomachs. Here. CI recommends it. Follow your CI. Okay, the spirometry we did yesterday. It's referred to as incentive because it's essentially biofeedback. Depending on how you have the machine hooked up, you get a visual of what the breath looks like. So you can use that with your patients to teach them to breathe more deeply, either on the inhale or the exhale. And you've probably all seen the little kind of plastic things with the tube attached that has like balls and things in it that the RTs use. We're going to play with those tomorrow too. Okay, what is the purpose of first lip breathing again, everybody? Back pressure. So what part of ventilation is it going to assist? Exhalation. Okay, last one we haven't discussed yet, segmental breathing. So in cystic fibrosis, sometimes even in COPD, one part of a lobe may be more affected than another. Or let's say they have a restrictive lung disease, so there's weakness. Or there's an abnormal spinal curvature, which then secondarily results in a weakness. You want to teach them to use the part of the lung, expand the part of the lung that's not being used as much. So we do what's called segmental breathing. Okay, so everyone place your hand on your lower right lateral rib. And just using a teeny bit of resistance, really more of just a tactile cue, breathe more into this lobe than any other. So try to get that section to expand more than any other.
I feel like it's the same on both sides.
Can you feel it expand? Now put your hands on both sides and see if you're doing more on the right than on the left. No. You're a jazz dancer, they call it isolation. No, anyone?
Not happening.
Okay, now assess the person next to you, see if they're doing it correctly.
I told you.
Hug each other.
I told you.
Okay. Sorry.
Come here, Chris.
Okay, I'm gonna turn this off.